falls. So independence, prevention, and safety. Next slide. So some things I'm going to go over are some risk factors to identify, reliable and valid assessments that the clinicians use, and then also discuss the interventions to decrease these falls, and then educate on how we can make a difference. Next slide. Okay, so some screenings is essential for fall risks. Early identification is definitely a big help, preventative medicine, to decrease these fall rates. A quote from the Journal of the Geriatric Society is, now that the Center of Medicare Services has announced funding for preventive care, healthcare providers must begin to screen for all fall risks as part of the normal preventative health care for older adults in the primary care office. Next slide. Okay, so what is a fall? The literature defines a fall as any unintentional loss of balance during routine activities, resulting in contact with the ground or a lateral lower level. Next slide. Okay. So falls, a health epidemic? I think so. 1 in 3 adults who are over the age of 65 will fall this year. About 20 to 30% of those falls actually sustain significant injury. Falls are actually the leading cause of traumatic brain injury and fractures in older adults. Falls are also the leading cause of emergency department visits by older adults. And falls are the #1 cause of hospital admissions due to trauma. Next slide. Next slide.
She left her post.
Oh, she's gone.
Hey, Charlie, can you hit right arrow, please?
Are you frozen again?
I don't know.
Caitlin's not there. She's under the red flag.
Yeah, where'd she go?
Charlie, hit the next slide button.
You muted.
Are we muted?
No.
I know, you're tired.
There she is. Okay. The number of adults ages 65 and older actually are admitted to the hospital after fall. Only about half of those will be alive in a year. It has also been estimated the average cost of those hospital admissions are usually about $20,000. And then by the year 2030, an estimated $54 billion will be spent on healthcare in indirect and indirect medical costs as due to those falls. Next, please. So repeated falls and instability are very common for nursing home admissions. Other older adults sustaining a prior fall are 3 times actually more likely to experience another one in a year's time. For older adults, falls are the primary cause for the loss of independent living, developing of fear, which may result in limiting one's physical activity and their social life. Next slide, please. So how can we make a difference? It's estimated that 2/3 of deaths due to falls are potentially preventable based on retrospective analysis of the causes and the circumstances of the falls. Effective fall prevention usually requires assessing the risk factors, managing them, and ensuring that interventions are provided. And that means more than one. Next slide, please. So we need to be familiar with the American Geriatric Society clinical guidelines, which I'm going to talk about a little bit. We also need to be able to identify those risk factors, and then we also need to be able to perform these screening assessments when appropriate, and then look to refer. Don't be afraid to refer. I know Dr. Vagliani said, earlier, don't be afraid to refer. Physical therapy, chiropractic, exercise physiologists, balance specialists, etc. About 30 to 40% mass reduction in fall rates are actually due to these interventions. Next slide, please. So why are the elderly predisposed to these falls? two big areas, high prevalence of clinical diseases. So those are your, lack of range of motion, osteoporosis, degenerative joint disease or DDD, and age-related physiological changes. Next slide, please. So these are just some things that are age-related physiological changes that kind of accompany falling or just getting older in general. So decreased reaction time, slower nerve conduction, slower onset muscle activity. A big thing that sticks out that I wanted to just kind of pinpoint was the elderly tend to use hip strategies over ankle strategies compared to younger people. So with the loss of balance, elderly people usually take a rapid step compared to weight shifting at the hip to maintain balance, and they also tend to lack dorsiflexion when they're striding. Next slide, please. Okay. So with fall risk factors, there's intrinsic and extrinsic. Intrinsic has non-modifiable things and modifiable, and extrinsic has modifiable, which I'll get to in a second. Some big things with the intrinsic factors that you can't really modify are age and gender. So two big things I want to kind of point out with that is if you're greater than or equal to the age of 85 years old, you're actually 4 to 8 times more likely to fall. And men are actually more likely to die from a fall, where women are more likely to fracture their hip. And then with the modifiable factors, fear of falling is a big thing that pops up a lot with the older population. And this can result from they have fallen before and that they haven't fallen before. They've heard stories about their friend Jane who had a fall and broke her hip, and now that kind of freaks them out. So that fear of falling can happen even if they didn't experience one. And that limits their social life, creates anxiety, also can create depression because then it's limiting those factors of, the biopsychosocial system. Next slide. Okay. So these are these extrinsic factors I was talking about that are more modifiable. Medications, actually, if you have greater than or equal to 4 prescribed medications, you do have an increased risk for falling. It'll look at home hazards, things around the house, rugs, carpets they're tripping on, dim lighting, their footwear, what are they wearing? Are they wearing good tennis shoes? Are they wearing, flip-flops, beat-up shoes, that kind of thing? Their assisted devices, that's a big one. I see a lot of people that aren't using their assisted devices properly, or they just went to the store and bought one without being told to. Usually a lot of the results are about 38% aren't using them correctly, 44% don't even have the right length for their height, and 54% the actual device is in very poor condition. And then their behavior, how they kind of accept that their body's changing, that they're getting older, those types of things. Next slide, please. Okay. So I kind of focused on a little bit earlier about the American Geriatric Society guidelines. So these are actually them being outlined. Older adults who are at risk for falling should be offered an exercise program incorporating balance, gait training, and strength training. Flexibility and endurance should also be offered, but it's not the sole component. Exercise should be included as a component of multifactorial interventions for fall prevention and community residing older adults. An exercise program that targets strength, gait, and balance is recommended as an effective intervention to reduce falls, but you don't want to use it solely. Next slide, please. Older persons who cannot perform or perform poorly on a standardized gait and balance test should be given a multifactorial fall risk assessment, and I'm going to talk about that in a bit. Older persons who have difficulty or demonstrate unsteadiness during the evaluation require a multifactorial fall risk assessment. The multifactorial fall risk assessment should be performed by a clinician or clinicians with appropriate skills and training. Usually most people refer out to physical therapy for this type of thing. Okay, continue. Okay, so some multifactorial assessments from the American Geriatric Society should include a focus history, a Part Q, that's getting all their basic intake information. Physical examinations focusing on like gait, mobility, strength, cognition, and cardiovascular wellness. Functional assessments, usually looking at their activities of daily living, current activity levels, and the patient's perceived abilities. So you kind of want to use a survey for that, and I'll talk about a survey in a little bit here that it's good to use. And then their environmental assessment. You know, who are they living with at home? Are they home alone? What kind of space they have? Those types of things. Go ahead to the next one. Okay, so there's single versus multifactorial interventions. This slide's just kind of showing, yes, you get some improvements with single interventions, but it's not the type of percentage that we want to see. Whereas multifactorial interventions, you know, getting involved with all types of medicine and staying linked between providers is important. The two supporting researches I have on there, one found that multifactorial interventions are actually superior to singular interventions, and then the other was looking at multifactorial interventions being more effective over just providing info and knowledge to the patient. And then you can see on the left just about how much exercise is definitely a good thing, but it can't stand alone to make a huge enough impact. Okay, continue for me there. Okay, so like I was kind of saying, it's teamwork. It's all about getting together and keeping those networking connections open between all types of providers, even including the patient. Okay, next. Okay, so primary care physician's role in this fall prevention. Screen all elderly patients, usually over the age of 65. Like I said, they're more prone to falling. So you kind of want to, that's your first, you know, red flag there. Are they over the age of 65? Okay, maybe we have to take a look at this. We want to kind of obtain a fall history, you know, the frequency of the falls, the circumstances, any symptoms that they may be having. We also want to identify any those risk factors that I talked about a little bit earlier.
Break point, if you have one in your thing, it's time's up.
Okay. We kind of want to ask the patients, you know, their fear of falling. So survey, the ABC is a good one, the activities balance confidence scale. 10 questions, gauging 0 to 10, how confident they are doing certain activities. You also want to assess their gait and balance. A time up and go test is great, 10 feet. Chair cross the line and back, timing that. Usually about 9 to 15 seconds is normal. If you're going above that range, you are at a high risk for falls. Above 30 seconds, you're looking at more needing assisted devices, using, you know, with the stairs, transfers, those types of things. And then just knowing when it's appropriate to refer. The FRAST, if anybody has heard of that, is definitely a good tool. Okay. Yep, we can break. That's a good one.
So Caitlin, she seems to think this is a good break point, and we can finish it up next time if that's okay, or at your discretion.
I think they're having tech issues. Sounds good.